The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right. Hi, everyone. Thank you so much for having me. I am really excited to be here. I think maybe some of you are wondering what in the world is a gastroenterologist doing on the MenMD platform. And believe it or not, I actually see a lot of men and women who are struggling with their weight. And many of it, a lot of it has to do with our hormones that are changing, stress and poor sleep. There are so many factors that play a role. So again, I'm very excited to be here and thank you all for joining. So today we're going to talk about obesity and what it means and what actually matters when it comes to metrics. And at the end of the day, a lot of it comes down to how do we improve our cardiometabolic health. So we're going to talk about the definition of obesity, how do we define it and how do we classify it, what metrics matter as it pertains to your overall health, and what is my role actually as a gastroenterologist, helping people not only reach a healthy weight, but more importantly, maintain that healthy weight. And then we're really going to focus on non-invasive strategies to improve our overall health and wellness as it pertains to our weight, including medical nutritional therapy and pharmacotherapy. So how do we define obesity? The problem is that all of the clinical trials define it using the BMI. So the BMI stands for body mass index, and it really only takes into account our height and our weight. When I have patients come into clinic, oftentimes they will have, let's say, a BMI of, let's say, 26, but most of their extra fat is actually around their midsection. So they may not actually classify as, being a candidate for these medications, although they have increased risk of cardiometabolic issues. But we use BMI because it's really easy to standardize over a large population. And that's what the FDA uses to actually do the clinical trials to figure out if people, whether or not they qualify for a study. So when we look at the different classifications, it's really a BMI of 18.5 to 25 is considered normal. Between 25 and 30 is considered overweight, and then 30 and above is obese. And then you have various categories of obesity, 35 and over, and then 40 and above. So again, we use these mainly for clinical trials. It's an easy metric to obtain in clinic, but it really doesn't tell us the full story. But the reality is despite all the advances in medication and devices and all the knowledge we have and research, the problem is that obesity continues to be a major, major problem. That if you actually look at the prevalence of obesity, of morbid obesity, of those with a BMI over 40, that is actually increasing. So clearly what we're doing is just not working. We have to really figure out how to make a dent in this huge problem. So nearly 1 in 3 adults are overweight. Over 2/3 of the population are either overweight or obese. Big, big problem. And there are still, people who have a high BMI who are healthy, but for many of these conditions that we have, high blood pressure, high cholesterol, et cetera, a lot of it is tied to a high BMI or extra weight. And then when we look at the prevalence of obesity among US adults, I know it's kind of hard to see here, but the darker red is actually over 50%. So as you can see, starting in 2011, 2012, there was more yellow with a prevalence of 25% to 30% of those folks in the States had obesity. Now the United States has much more orange and red, which is the higher prevalence. So again, clearly what we're doing is just not good enough. We can do better. And a big part of why I'm here today is it all comes down to education, empowering our patients, our community to understand how our body works and how we can overall optimize our health and live our best life at any age. So what are the pros and cons of using BMI? So I used to work at an academic center where I was seeing maybe, 20 patients in a day, and the nurses were really busy. They were rooming patients in and out. So a pro to using the BMI is it's easy. All we have to do is oftentimes just ask you what your height is and get you on the scale. So it's easy to measure, it's easy to calculate using a very simple formula. It helps standardize things. So if you're doing a large study, it's easy to classify people to figure out whether or not they qualify for it, again, using this BMI. We know that some of it can actually correlate with health risks. So higher BMIs are associated with increased risk of really all chronic conditions, whether it's type 2 diabetes, heart disease, venous disease or arterial disease, dementia, fatty liver, sleep apnea, joint disease, etc. But it doesn't tell us the full picture, like I mentioned. So I'm a gastroenterologist. I saw a lot of patients who suffered from chronic liver disease. So their BMI may actually be a little bit hard to interpret, because patients with liver disease like cirrhosis or heart failure, they're holding on to a lot of water. So sometimes it may actually overestimate someone's fat mass because they're retaining a lot of water, whether someone's on dialysis, congestive heart failure, or end-stage liver disease. Or I actually have patients, because I also do sports nutrition, who are bodybuilders. And oftentimes I get them on the scale, and based on that BMI, they're actually considered obese, when in fact they just have a very low percentage of body fat. But because they're a little bit heavier, because they have high muscle density, it actually incorrectly classifies them as having a BMI, even though they don't have any of the associated health risks. So there are some populations where it can be helpful, or at least give us something to trend. But the reality is it's just not a great measure because of other things that are more important. So this is fat and this is muscle, okay? So we want more muscle, less fat. And depending on where that extra fat is distributed, that actually has huge implications on our cardiometabolic health. So if someone gains fat and it goes to their arm, that's really the subcutaneous fat. That's the fat that you're pinching. Although it may not be aesthetically pleasing to some, very little of that actually gets dumped into our systemic circulation and drives up our total body inflammation and risk of other chronic conditions. The problem is that oftentimes as we get older, when we gain weight, more of it actually goes to the midsection. So it's like when women are going through menopause, it's the menopause belly, or men will call it like that spare tire, the love handles are in front. And so that's the fat that's actually bad. It's what we actually call visceral fat. The larger someone's waist circumference is, that correlates with more fat in the organs. And the more fat in the organs, whether it's the heart, the liver, the pancreas, etc., that is what increases our total body inflammation and is really a trigger for all chronic diseases. Again, whether it's diabetes, high cholesterol, cardiovascular disease, dementia, fatty liver, you name it, it's that visceral fat that matters. And the BMI does not discriminate whether someone's gaining fat in their arm or whether someone's gaining fat in their belly. So what I use at Prime Institute is actually a Seika bioimpedance scale, and that's a medical grade scale similar to something like an InBody, which you may see it like some of these typical gyms that they may offer, or you may actually get a DEXA scan, which is really like the gold standard for body fat assessment. But any of these can actually help tell you how much muscle do you have, what is your body fat percentage, and on my scale and a DEXA scan, it will tell you actually how much visceral fat you have. So those are the metrics that matter. Although what brings people into my clinic is they want to lose weight, I'm ultimately trying to figure out how can I improve someone's cardiometabolic health so we not only prolong their lifespan, but we improve their health span. And we know that extra fat cells actually promote inflammation. So even if just someone has the extra fat around the midsection, it's affecting every organ in your body. And from a gut perspective, a lot of my patients have like irritable bowel disease, or I also see patients with Crohn's or colitis, which is an autoimmune condition. And what we know is that when we drive up total body inflammation, it can trigger some of these autoimmune conditions. Or for instance, people will say, oh, my elbow's bothering me or my shoulder's bothering me. Now, although the fat's in the midsection and it's, let's say the shoulder is not a weight-bearing joint, it's not like the knee. The problem is the more fat cells we have, that drives up total body inflammation. And so every organ feels it. So the goal is want to shrink these fat cells as much as possible. Now, we had some questions actually on how do we get rid of the belly fat. And unfortunately, folks, you could do a million planks or a million sit-ups. It doesn't mean the fat's going to come off the belly. We cannot spot reduce. So the goal is you actually want to gain as much muscle as possible. When we gain muscle, or if we're on an active weight loss regimen, we want to maintain as much muscle as possible That's what helps us maintain our metabolic rate. It helps us burn more calories like a furnace. And then ultimately that weight will come off the midsection. But it takes time, and a lot of consistency. All right, so let's talk about causes and symptoms of excess weight. So causes, what raises the risk of being obese? Now, genetics, I know it's lower on the list. Genetics is a big role. Our environment, of course, certain medications, we got some questions about starting antidepressants or being on a beta blocker for heart disease. Although these medications are very helpful in certain aspects, the problem is many of these medications can cause weight gain. And a lot of them are actually the antidepressants and some of the cardiac medications like beta blockers. So again, although they have, powerful impacts, whenever you're starting a medication with your provider, and if you're worried about weight gain or you're struggling to lose weight, ask them, is this a medication that will cause me to gain weight or make it more challenging for me to lose weight? Oftentimes there are other options that are less weight promoting. So always ask that question, because unfortunately as a provider, we're not always thinking about that. And once you put on the 10 or 20 pounds or more, it's really hard to get it off, okay? Lack of physical activity, a big one. So many of us are stuck on Zoom or meeting after meeting. We don't even have time to go to the bathroom. So it's all about how do we integrate more movement within our busy workday. And we're going to go over some great tips for that towards the end. So unhealthy eating behaviors. My goodness, I came across a crazy realization recently when I was eating a protein bar, and it told me that it was only contained like 4 ingredients, and blueberries wasn't listed as an ingredient, but yet it was blueberry flavored. So then I looked up what exactly are natural flavors. And what I realized is that whenever you see something that says natural flavor on a product, that natural flavor actually contains about 100 chemical compounds. It's crazy. So our ultra processed food is really killing us. It has, a lot of these items have high calories, but they don't have the nutrients that we need. For instance, like some of these like salted caramel cream espresso Starbucks things, it's only got a couple grams of protein, but 15 grams of sugar and 11 grams of added sugar. Even things that are seemingly healthy, like protein shakes, they are ultra processed. Really, anything that has more than like 5 ingredients is ultra processed. If you can't make it at home easily, it is ultra processed. And the problem is that our brain is really wired to need protein. Protein is the only macronutrient we actually need to survive. And if our body is not getting protein or nutrients, our body is saying, eat more, I'm not getting what I need. So although we're getting calories with these ultra processed foods, it actually ends up stimulating more hunger to eat more and stimulates more cravings. And then just unbalanced diet. So let's say we go out to a restaurant, we eat a bunch of bread, and then we get a baked potato and maybe, a small amount of steak. Well, there's really no fiber in there. So we have to figure out how to have a little bit of everything to make sure that we also protect our gut health. Lack of sleep, holy cow. I didn't realize the importance of sleep until I injured my wrist and couldn't sleep for 2 months. Sleep has incredible power over our overall health and wellness. And really it's aiming for, 7 to 8 hours of good sleep a night. When we don't get good sleep at night, our brain actually has a really hard time detoxifying all the chemicals and toxins from that day. So it's really important for mental clarity, reducing our risk of dementia, improving really our heart health. It affects every organ in our body. It is not just being tired during the day. It really has a huge impact also on insulin resistance. Obviously, some certain health conditions can be linked to obesity. Anything that drives up cortisol. Cortisol is a stress hormone. And so that can definitely lead to more difficulty losing weight or weight gain. And then insulin resistance. So whether you're insulin resistant or have prediabetes or diabetes, insulin is a fat storage hormone. So as insulin levels go up, we tend to store more and more fat, and it's harder to get rid of it. Hormonal imbalances. 300%. My goodness, these happen to every single one of us. Every woman on this planet is going to go through menopause, and our estrogen drops, our progesterone drops, and so does our testosterone. And in men, as we get older, every decade, testosterone tends to drop. Now, not every man is going to have low testosterone, but if you do, it is a hell of a lot harder to lose weight when your hormones are not being optimized. So again, lots of reasons why people struggle with their weight. It is far more complicated than just saying, oh, we're eating too much and not moving, enough. There's a million other things that contribute that make it more challenging. So what are some common symptoms associated with being overweight or obese? It's being out of breath. It's something as simple as bending over to tie your shoe and you got to kind of catch your breath there. It's having daytime sleepiness or just fatigue, headaches, heavy sweating, joint pain, just having extra pressure and walking around with extra weight puts a lot of pressure on your weight-bearing joints like your knees and your hips. Low confidence and self-esteem, feeling isolated, absolutely increased risk of anxiety and depression and disordered eating patterns. So many people struggle with this experience. It is a common experience. I think, unfortunately, far too often, these conversations don't come up in typical healthcare scenarios because they take time. And they also really, we need a safe environment for these conversations to happen. And often within the healthcare scenario, you get 15 minutes with your healthcare provider, you're in and you're out. It's really hard to develop rapport with the person sitting in front of you and express a lot of these concerns. So when should someone consider losing weight? Now, a lot of what I do is education. So I don't, want to wait until someone has a BMI over 25 to say, now there's something we need to do about it. I think everyone deserves a conversation with a healthcare provider. Everyone deserves education to understand how to live their best life, really at any weight. But people who are higher risk would be those individuals with a BMI over 25, particularly those with a BMI over 30. And then really any health condition that's linked to obesity, and there's a million out there, whether it's insulin resistance or prediabetes or diabetes, heart disease, high blood pressure, sleep apnea, even asthma, certain types of cancers. There are 13 different types of cancer that are linked with obesity. Anyone who's experiencing issues with mobility, that's a big problem. And the more weight you have on, it's just harder to move around. Any woman who's planning to conceive, any people with a family history of obesity-related conditions, really everyone should have the opportunity to talk to a healthcare provider, someone who has expertise in nutrition and weight management at any point in their life. And another reason why I'm doing this today is really it all comes down to education. I want you all to understand, why does it matter to you at this point in your life? What questions should you be asking your provider so that when you're sitting in front of them, you are well versed in the questions that are important and understand what are your options. Because again, oftentimes it's a pretty rushed visit that you may not have enough time to then think of questions on the fly. So it's all about, being prepared and understanding why it matters to you. So, my struggle when I was in my prior practice and some of these visits were rushed is, how in the world do I meet someone for the first time? I establish this rapport prior to discussing often a very sensitive topic when it comes to weight, learn about all their medical problems, their prior failed weight loss attempts, their coping strategies. What does the family unit look like? Do they have kids? Are they taking care of, elderly parents? What is their support system, their budget, their time constraints? And within like a 30-minute span, then teach people nutrition basics and then potentially start them on medication and counsel them on all of this within 30 to 40 minutes. It's a real struggle. And I get all these questions, and I got a bunch of these questions too for tonight. Is fat bad, or should I actually be doing a ketogenic diet? Are carbs the enemy? How much protein is too much? Should I do keto? And what about intermittent fasting? So we got a couple of those questions. So these are real questions. People struggle with what diet to do. There's a million and one diets out there. And the reality is any diet works, at least for the short term. Because if you restrict the types of foods you're eating or you restrict calories, people will lose weight. But at the end of the day, we got to figure out what is realistic long term. If we do a keto diet and we're not eating any fiber and now we're super constipated and there's only so much bacon and salmon I can eat, and then I basically come off that diet, go back to my prior diet and gain all the weight back, and oftentimes we gain even more weight back because we lost muscle. So it all comes down to, what foods do we like? What do we not like? But ultimately, we have to eat enough protein. Protein is the building block to really maintaining as much muscle as possible. And that could be a lower carb diet, a lower fat diet, doesn't necessarily matter. As long as we're really focusing on whole foods, good sources of protein, and then figuring out what that looks like in a day-to-day scenario. So let's talk about the basic anatomy, because this is really important for when we start talking about the medications. All right, so what is the gut? We hear this term all the time. The gut actually comprises a couple different components. It's the gut epithelium, or the lining of the gut, and that includes actually the barrier system, like the mucin layer. GALT is actually our lymphatic tissue. So believe it or not, our largest immune organ is actually our gut. So we want to eat really good food to help promote a healthy immune system. Our enteric nervous system. So oftentimes, whatever's going on up here in our brain actually affects our gut. You all have probably heard the terms like I have butterflies in my stomach, or I have a nervous stomach. That's because we have nerve endings and neurotransmitters that connect our brain to our gut. So if we're anxious, we're sad, we're bored, we're happy, many times people actually feel that in their midsection. Or if people have a GI related condition, that can then send signals to their brain to then actually trigger anxiety or depression. And then the microbiome. So believe it or not, with the microbiome, we have billions of bacteria in our gut. We have more bacteria in our gut than we actually do human cells in our body. It is fascinating. The microbiome plays a huge role in whether we're healthy or whether we have a lot of chronic disease. And the way to help promote a healthy gut microbiome is eating whole food and dietary fiber. So whether it's adding, let's say, hemp seeds, or these little dehydrated apple chips, or these little, what's some of my favorites, beans in a bag, it's dietary fiber that helps promote a healthy gut. When we have a healthy gut, that microbiome takes care of us. All right, digestion and absorption. So let's go over normal structure and function. So digestion actually starts in the mouth, believe it or not. We have enzymes in our mouth that actually help break down carbohydrates. So when we put food in our mouth, it actually starts with mechanical breakdown of the food. We have to chew our food. I know I'm guilty of it too. I shovel food in my mouth. I can barely chew it because I'm, let's say, rushing in between seeing patients. So chewing the food is very important to mechanically break it down. That allows the enzymes in the mouth to then further break down those carbs. Then the food bolus goes down the esophagus and then into the stomach. So the stomach is really where further digestion occurs. The stomach kind of contracts, releases more enzymes, and releases enzymes that actually help break down protein, as well as acid that help break down food. It takes a normal stomach 4 hours to empty a typical meal, like an egg sandwich. On these medications that we're going to talk about, these medications actually delay gastric emptying, so the food actually stays in your stomach longer. So then, and liquids actually empty faster. So for my patients who struggle with getting enough protein, we often change to protein shakes to allow them to get more, but not feel so full. So that's the stomach. Then the food travels into the small intestine and then the large intestine, and then exits through kind of the pelvic floor, the rectum, and then out the anus. So that's the typical GI tract. And what happens with these medications that we'll discuss is glucagon-like peptide 1, which is the hormone that a lot of these medications, they are synthetic versions of. That hormone is actually released from the small intestine after we eat. And that hormone sends signals back to the brain, and it says, brain, I'm full. And it takes the brain about 20 minutes to actually get those satiety signals to know that it's full. So that's why actually chewing our food and allowing our bodies about 20 minutes in a meal to eat, a small portion, eat the protein and the fiber, and then give it 20 minutes and then ask ourselves, are we still hungry or are we satisfied? It's all about eating until we're satisfied. Once you eat until you're full, you've likely eaten too much. All right, so weight management strategies. So the majority of my practice is the medical nutritional therapy and exercise programming and pharmacotherapy. But there's also other options like endobariatrics, where we can actually put a balloon inside of your stomach via endoscopy. There's the endoscopic sleeve, where you can actually suture the stomach and do a sleeve without any surgery involved. It's all through an endoscope. And then bariatric surgery. So bariatric options would be something like the lap band, which is not done so commonly these days, the gastric sleeve, the Roux-en-Y gastric bypass, or the duodenal switch. So I always start with, obviously, the medical nutritional therapy and exercise. That is the foundation. So whether you're doing, let's say, a diet and exercise alone, with or without medication or any of these surgical or procedural components, the foundation for long-term weight loss and improving cardiometabolic health is you cannot skip over the nutritional piece and the exercise. All right. So although what brings people into my clinic, and I'm sure a lot of you are interested, is how do we lose weight? It's not necessarily the most important thing. People want to feel well. So it's about understanding, how does food affect our body? How do we eat well to feel well? How do we prevent chronic disease? How do we treat chronic disease? How do we improve whatever quality of life concerns matter to you at every step of your life? And this is going to change. It's very dynamic, whether it's improving your athletic performance or your sexual health or improving your pain or mental well-being. Ultimately, that's what matters. But if we can get someone to a healthier weight, all of these things can improve. So how much weight loss does produce benefit? It really starts with about 5 to 15% of your weight. So if I have a patient who, let's say, is 250 pounds, if they lost anywhere from 12.5 to 37.5 pounds, they would be a much healthier version of themselves. So I think a lot of people tell, themselves, oh, I need to lose 50 pounds in order for it to matter. From a metabolic standpoint, whether it's improving fatty liver, blood pressure, or cardiovascular risk, or sensitizing our body to insulin, for many people, it may be as simple as, 10 to 30 to 40 pound weight loss. And it's not a simple equation. So, I was taught way back in the day, oh, it's a simple numbers equation. As long as we eat less and move more, we'll lose weight. We're learning more and more that that's actually very far from the truth. When we have insulin resistance and other conditions, it becomes far more complicated. And the reality is that only about 10 to 20% of people who need to lose a significant amount of weight will be able to do it with diet and exercise alone. Weight regain is very common, really with any of these techniques, whether it's diet and exercise, medication, or bariatric surgery. Weight regain can happen, and we'll talk about why that happens, but it's far more than just a numbers equation. Whether it's genetics, as we get older, it becomes harder. Our hormones are changing. I have plenty of women that see me, they were 110 pounds most of their adult life. They go through menopause, they gain 20 pounds, and it all goes straight to the gut, and they're really struggling, even though nothing changed with their nutrition or exercise. Stress, sleep patterns, again, the type of food, all these things make it far more challenging than just eating less and moving more. So why is weight regain so common? It's not that you're doing anything wrong. The body is trying to fight against it. Your body, as much as you're not comfortable where you may be, your body wants to stay exactly where it is. It is a survival mechanism. Our bodies have not evolved. So let's say 100 years ago, if our body was sensing less calories and more movement, it thought we couldn't find food and we were running from a bear or a tiger. And so we were more likely to actually die from starvation than die from, let's say, gaining weight or obesity. So it's a survival mechanism that our body has not evolved away from. So the problem is that as we lose weight, a couple things happen. If we lose muscle, which is very common, even if it's just diet and exercise alone with medication or bariatric surgery, if we lose muscle, our metabolic rate drops down. The other things that play a role is as we lose weight, our muscles become more efficient at burning calories. It's called metabolic adaptation. So the same exercise we're doing at 200 pounds, if we lose 50 pounds, if we do the same exercise, same duration, same intensity at 150 pounds, we're going to actually burn less calories doing it. So at a lower weight, we actually have to eat less and move more just to maintain that weight loss, even if we don't want to lose extra weight. So that's really where the challenge lies. The other issue that happens is that at a lower weight, again, our body wants to go back to where it came from. And so our hunger hormones go up and our fullness hormones go down. So at a lower weight, you're no longer satisfied with your typical meals and you're more hungry and there's more food noise. So it's really challenging to keep it off. You may go back to, a little bit of what you were eating before, and then all of a sudden the weight comes back on like that. So there's a lot of hormonal changes that happen when we lose weight. It's a very dynamic process. And it's really not a one-size-fits-all approach. There are some people that are just interested in, Doc, what can I eat today? How can I plan my meals so that I can eat better, feel good, improve my gut health, and lose weight? That's one approach. Then you have obviously the lifestyle and exercise. That in combination with the nutrition is, again, the foundation to everything else that we're going to talk about. And then medical intervention. So now let's dive deep into the medication options that are out there. And talk about nutrition first. Next. All right. So I don't put anyone on a diet. My goal is to understand, where are they coming from? What sort of foods are they eating? What are their preferences? What are they sensitive to for? Do they have time to cook? I need to understand what that home life looks like and what's reasonable. But in general, this is where I start with every one of my patients. A lot of people are getting extra sugar just in the liquid. So oftentimes I'll actually just target the liquids first and not tackle the solid food until, let's say, month 2. So it may be something as simple as, taking out one of these canned Starbucks drinks, and automatically that's eliminating 14 grams of sugar. Now, that also includes artificial sweeteners. So a lot of these quote unquote healthy protein shakes have a million ingredients, including artificial sweeteners, which can actually mess up our glucose homeostasis and trigger more cravings for more sugar. Artificial sweeteners are 300 to 600 times sweeter than natural sugar. So it trains our brain to constantly crave something super sweet. We have to get used to actually eating fruit and having the natural fruit be satisfying enough. So I usually target actually like the diet sodas, the regular sodas, the juice, what's in the coffee. If we have 1 or 2 cups of coffee a day, that's fine. The problem is, are we adding sugar packets or honey or regular milk to the coffee? So it may be something as simple as changing from regular milk, which often has 11 or 13 grams of sugar, maybe 6 grams of protein, to switching something to like Fairlife milk, which has twice as much protein, half as much sugar. So I start with the beverages. And oftentimes that, really includes a lot of the added sugars. But then other things like some of these yogurts out there, Yoplait, my goodness, you may as well have a candy bar for goodness sake. So it's really about eliminating added sugars. So it may be something as simple as, instead of getting the Fage Greek yogurt that has like the fake fruit on the side, maybe do the plain, and then you just add, let's say, some dehydrated apple chips on top, or some fresh berries, or cut up an apple. It's getting rid of the added sugars like the high fructose corn syrup. And then the added salt. So there's salt in everything. If you're adding additional salt to food, you're oftentimes just over consuming salt, and that can also lead to water retention, high blood pressure, amongst a lot of other chronic conditions. And then the trans fat. So really anything that's fried, we probably shouldn't be eating, especially if we're on one of these like GLP-1 medications. Too much fat in the stomach can really cause a lot of nausea and diarrhea, particularly if you're on these injectable meds. All right, so exercise for weight loss. So exercise, unfortunately, is not a good tool for weight loss. So I have plenty of patients that spend a lot of money having personal trainers, and although they're improving their overall health, many of them are not actually seeing the number on the scale that they really anticipated seeing. But it's incredibly important for every aspect of our health other than weight loss: our mental well-being, our cardiovascular health, our pulmonary health. And really from a weight loss perspective and weight management perspective, it's actually all about maintaining as much muscle as possible, minimizing muscle loss, and really optimizing fat loss. And that's really where resistance training is incredibly important. So I have a lot of patients who are super busy, and it may be something as simple as wearing something like a weighted vest. So this baby right here is 8 pounds. I go walking with this, I'll go on the stair mill with it, or I'll go on the treadmill, adding about 10% of your ideal body weight. So let's say someone's 120 pounds. If they wear, let's say, a 12-pound weighted vest, there's actually data to show that that actually improves your bone health and your muscle health. So figuring out how to add resistance into your normal activities can be very helpful. But in general, we should be doing at least 3 days of strength training a week. Cardiovascular exercise is important, but if time is limited, then really prioritizing the strength training is really the critical part. Cardio, too much cardio, can actually drive up cortisol levels, increase hunger, and actually lead to muscle loss. So again, strength training is critical, 2 to 3 days per week. But if you're starting from nothing, then maybe start with like a 20-minute session of just doing some basic resistance bands or 5-pound dumbbells, really focus on that eccentric phase. So 2 seconds up, 4 seconds down during that muscle lengthening phase. That's really what helps with recovery, resilience, and injury prevention. All right, so let's dive into the medications here. So medications, obviously the FDA has done a lot of studies on this. There are certain indications. Now, I will say that there are many people, including myself, who use these medications off-label. If I, can help someone and provide a tool to help them get to a healthier weight and improve their cardiometabolic health, then I'm all for that. But really, when it comes to the FDA, as far as indications for these injectable medications, and for most weight loss medications, it's those with a BMI of 27 or greater with an obesity-related comorbid condition, or those with a BMI of 30 or greater, and you don't have to have an additional health condition with that. So this is just a very broad overview of the medications on the market. Believe it or not, since the beginning of time, we only had about 5 medications that were FDA approved for weight loss. And actually one of them, Belviq, was actually taken off the market for side effects. So it wasn't until actually 2021 when Wegovy came out that we finally made headway actually in the obesity space that not only helped people lose weight, but improved all these other markers that really matter from a health perspective, from potentially, reducing total body inflammation, fatty liver, protecting our heart, sensitizing our body to insulin. So it goes well beyond just losing weight. So this is just a schematic looking at the first generation weight loss medications, which were the only options that we really had that were FDA approved up until 2021. So someone had asked a question actually about phentermine. Phentermine is actually only FDA approved for a 3-month period. Now we can still prescribe it longer than that, but as you can see here, the weight loss is only about 3%. So if we're trying to improve someone's cardiometabolic health, and as I mentioned earlier, we're really aiming for 5 to 15% weight loss. As you can see here, most of the medications on the market up until 2021 didn't actually reach that metric of the 5 to 15%. Many of them were really short-term medications like the phentermine. Hydrogel is basically just an expensive Metamucil that expands in your stomach and cause gastro issues. Orlistat is actually no longer recommended. It's a fat blocker. I'd have patients who were having like fecal leakage, which most people are not going to be happy with. There's a combination of naltrexone and bupropion, that's Contrave. I usually use that medication. It's an oral medication in my patients who, let's say, are having depression or have kind of binge eating tendencies related to their mood. Bupropion is an antidepressant. The other name for that is Wellbutrin. Naltrexone is actually used for patients who are trying to get off alcohol. So that medication I found in some individuals who tend to have more binge eating tendencies related to depression and who are trying to minimize their alcohol intake. And then the phentermine combination with Topamax is another option. That's Qsymia. But again, the Topamax can make people feel kind of dopey, and the phentermine can have a whole host of side effects, including palpitations, insomnia, dry mouth, and constipation. So for my patients who had cardiac issues, some of these medications like the Qsymia and phentermine were contraindicated. So we really did not have that many options. All right, so let's get into my favorite part here, which is the GLP agonist and the dual GLP-1 and GIP agonist. So these medications actually in this drug class have been around longer than actually most people realize. Victoza was the first medication, or liraglutide, that came out around 2005. Then we started seeing people actually as a side effect, they were losing weight. They did additional studies, and the medication that came out was called Saxenda. So those two medications is Victoza for diabetics, Saxenda for weight loss, were the two kind of initial GLP-1 agonist injectable formulations that came out back in 2005. But it wasn't really, rampant within the press and the media, and a lot of patients didn't necessarily know about it. More recently, Ozempic came out in 2018, so that's semaglutide. So I'm going to show you here my little platter of pens. So Ozempic here is FDA approved for diabetics and comes in a multi-dose pen. So it can last you, let's say, from 4 weeks to 6 weeks, depending on the dose. That's Ozempic, also known as semaglutide. The non-diabetic weight loss version of Ozempic is Wegovy. Wegovy is this pen here. It comes in a single dose pen where the box comes with 4 pens. So it's 1 pen per week at a set dose. Again, those are both the exact same medications. They are both semaglutide. They just have different FDA indications, and the doses are slightly different as you get to the higher doses. Then, most recently, Mounjaro came out, I believe, a couple of years ago, I think around 2021 as well or so. Mounjaro, again, a single dose pen, that's tirzepatide. This medication FDA approved for diabetics. And then the non-diabetic version, newest on the market, is your Zepbound. Okay, so Zepbound, again, tirzepatide, single dose pen, that's right here. So they all come in either single dose pens or multi-dose pen delivery systems. Now, again, one is semaglutide, one is tirzepatide. They're both very effective. They all have very similar medications. So although we're hearing all the hype now, medications in this drug class have actually been around for quite long. How do these medications work? They have 1,000,001 mechanisms, many of which we actually don't quite understand yet, but the main ones are actually on the brain. So we have reward centers in our brain, we have receptors for these hormones in our brain, and they help dampen that reward response. So we get less pleasure from eating foods, particularly like fatty foods and high sugar foods. So that's a great way to tackle part of the issue. The other thing that it does is these medications are a synthetic version of the hormone our body naturally makes. The problem is that our body breaks our natural hormone, the GLP-1, down pretty damn quick. So with this synthetic version, it stays in our body much longer. So it not only slows down the rate at which our stomach empties, so the food stays in our stomach longer, it also then sends signals back to our brain and gets us full sooner, okay? So delayed gastric emptying works on the brain, reduces food cravings and reward pathways. Okay, so which are the most common medications out there? So the ones I use in my practice and the ones that are most commonly used with weight management practices would be semaglutide. Ozempic, FDA approved for diabetics. Wegovy, non-diabetics who are overweight or obese. Tirzepatide, Mounjaro for diabetics. Zepbound for non-diabetics who need to lose weight. Liraglutide, Victoza for diabetics. Saxenda for non-diabetics who need to lose weight. Now, liraglutide just doesn't have as robust weight loss, so it's closer to maybe like 5 or 7% weight loss. The most effective medication on the market currently, FDA approved in the market, is actually the Zepbound, and that's what I use a lot in my practice. So again, how does it work? I just went through the mechanisms. How is it administered? So it depends on the pen delivery system. Typically, the easiest place to do it, it's subcutaneous, so it goes into the fat. Some people will do the arm, but oftentimes you need help doing that because it's really hard to do it yourself. Most people are going to do the belly or the upper thigh. So you have to grab, you'll wipe, let's say you hop in the shower, you wipe it clean, or you can use an alcohol pad and grab a fold of fat. You, depending on the pen delivery system, you would put the needle on the pen, put the needle in. After you've adjusted the dose, you press the button, and then the medication's administered. These needles are very small. They're much smaller than a typical phlebotomy needle. So I think a lot of people are nervous about the medications because it seems like an injectable medication is very drastic. And I don't know if you can see it here, but I'm going to show you a little demo on the needle comparison. So this needle here, it's kind of hard to see, is a typical like phlebotomy needle. The needle here, you can't even see it, is actually the typical needle for like Ozempic. So it's very tiny. So I know it sounds like an aggressive thing to do an injection, but many of my patients don't even feel it. Okay, so this is really just a schematic showing that these medications and these hormones have such profound impacts on most of the organs in our body, whether it's reducing appetite and food intake, increasing satiety. It has kind of total body effects as it pertains to decreasing inflammation. So it goes well beyond just the gut, well beyond just the brain. More and more FDA indications are coming out, which I think is a beautiful thing. Clinical trials going on in the realm of fatty liver and dementia and alcohol abuse. So this field is rapidly, rapidly expanding. And it's a beautiful place to be at this point in time because we finally have options to really help people long term. Next slide. Okay, so some key points here. These medications, these injectable medications, your second generation medications, helps get you fuller sooner, keeps you fuller longer, allows you to eat less and still feel satisfied, and reduces cravings. Contraindications would be a personal or first-degree family history of medullary thyroid cancer or a very rare endocrine disorder called multiple endocrine neoplasia type 2. Otherwise, these medications are fair game, at least in my practice. I oftentimes use medications more aggressively up front in hopes that I can get people off other medications in the future. All right, so is it too good to be true? Well, there are potential side effects for everything. It doesn't matter what medication or supplement, there are always potential side effects. About 7% of people in the clinical trials had to stop the medication because of a side effect. What are the most common side effects? Well, remember I told you that it's a gut hormone, and a big part of the mechanism is it affects the gut and delayed gastric emptying. And so what happens is that if we eat, let's say, too much, we eat too fast, we eat too late, we eat really fatty food, the fat stays in the stomach longer, then people often have nausea, acid reflux, bloating, vomiting. Some people get diarrhea, some people get constipated. If you were to compare semaglutide versus tirzepatide, or let's say Wegovy versus Zepbound, people tend to actually have less side effects with Zepbound versus Wegovy. So in my patients who have chronic GI issues, they tend to actually do better with the Zepbound formulation. If you experience these symptoms, we obviously want to go back to the drawing board and figure out how can we minimize them. The goal is not to feel sick in order to lose weight. The goal is not for me to give someone a medication to then cause 5 other things and then give them 5 more medications. But we do treat the nausea. We know from the data that the more nausea someone has, it doesn't mean they're more successful with their weight loss. So if you're suffering from that, talk to your provider. We can still give you anti-nausea medications to help you get through it. But oftentimes it's something that we're eating. So we have to go back and say, okay, eat some bland foods right now, cut out some of the fat, don't lie down after eating, try to eat slower, try to eat smaller portions. And then again, we want to treat through it to make sure we kind of get you over that hump. These medications are once weekly injections. So keep in mind, if you're starting a medication for the first time, and then you have a birthday party the next day, you're going on a trip, just be cognizant that if you have side effects, those side effects may linger, anywhere from, let's say, 3 to 7 days. So I wouldn't be starting the medication or increasing a dose before you're doing something new that's out of your routine. So really the goal here is not just to lose weight, it's to minimize side effects and prevent excessive muscle loss. So for me with my patients and really, people who are experts in the field, we know that we are not selling weight loss. We are trying to improve someone's overall health so that 5, 10, 20, 40 years from now, you're at a healthier weight, but most importantly, you feel good and you feel strong and health is not holding you back. But it's the steps we take today that will influence how we live those next 2, 3, 4, 5, 6 decades. So we want to start with, how do we minimize side effects? Eating less. Okay, we can always eat more, but if we're on these medications and we ate too much, we're just not going to feel well. So start with serving yourself about half the portion of your normal portion. Give yourself 20 minutes and then ask yourself, am I satisfied? If you're satisfied, you put the rest of the food away. If you're still hungry, you can always eat more. If you're really full and busting at the seams, you probably ate too much. And then tell yourself your next meal, you're going to cut down on the portions. Always eat the protein first. Protein is the critical piece here to supply your muscles with enough amino acids to maintain muscle. So if you just eat, let's say, a slice of bread and you're full and you have a slice of bread and butter and you're not getting protein, you're going to be too full to eat the protein. You may lose more weight. You're going to lose a lot of muscle and increase your risk of sarcopenia, increased risk of frailty, and weight regain. Try not to eat within 3 to 4 hours of lying down. You don't want to go to bed with a stomach full of food. And it takes the normal stomach 4 hours to empty. And on this medication, it's going to be delayed even more. If you're struggling to get enough protein, and most people need bare minimum 60 to 80 grams of protein to start, and oftentimes more than that, really try to have your larger meals earlier in the day, and then substitute some of the solid meals with maybe some smoothies, or maybe have some bone broth and add some collagen protein to it. Remember, liquids empty faster than solids. So if you're someone that's struggling to get enough protein on the medication, then liquids can be a better source. But you want to choose options that are not ultra processed. So adding the collagen protein to, let's say, some bone broth or soup or a homemade smoothie, still a much better option than some of these ultra processed protein drinks. And then how long will you be on medication for? We really don't have any clear guidelines. Every person is different. But the reality is these medications were developed for long-term use. The data shows for people who are on these medications, like Wegovy or Zepbound or others, when we stop them abruptly, around month 2, people start regaining the weight. And when they regain the weight, they're not regaining the muscle that was lost. So if you're going to go on a medication, understand that it's not just something you're going to go on for 1 or 2 months, unless you're having side effects and you don't like it. But if you lose a bunch of weight in 1 or 2 months and then expect to just stop the medication and maintain all that weight loss, that's not typically what happens to people. But in the future, if you want to maximize your chances of coming off the medication, you have to make sure you're maintaining as much muscle as possible from day 1. Do not wait until you get to your goal weight to then say, okay, now I'm going to eat more protein and now I'm going to do resistance training. Once you've lost the protein, it's a hell of a lot harder to gain it back. So what I do for a lot of my patients is once they get to their maintenance, we start spreading out the injections. So maybe they just need an injection every 2 weeks or so to help kind of keep their hunger hormones down and their fullness hormones up. Okay, so some take-home points here. It's about making better choices, not perfect ones, starting today. It may be something as simple as swapping out your Starbucks high-sugar drink for black coffee with Fairlife milk. A simple change like that, again, starting tomorrow. Or swapping out the Yoplait yogurt for the plain fajita that has a lot more protein and probiotics, or a plain cottage cheese, and this one actually has 19 grams of protein. Nutrition and exercise are the foundation. So whether you're just looking for lifestyle changes, medication, endobariatric surgery, or surgery, in order to keep the weight off for good, feel well, do what you want later on in life, and not be restricted by your health, nutrition and exercise is a conscious, daily, consistent effort that has to be implemented. Medications are a phenomenal tool out there to help people. The struggle is finding the provider who has the expertise, who can guide you through it. But there are more and more clinics out there that are making it more accessible. The more you can do to educate yourself, so when you go to your provider, you know what the options are, you have your questions ready to go, and advocating for yourself. We're in a time and a place where really this field is rapidly expanding, and it's a beautiful place to be.
Alrighty, let's go to the Q&A. So we're going to ask a handful of questions here. The first one is, how can hormones affect my appetite?
Yeah, so there's a lot of hormones in our body, one of them being cortisol. Cortisol is our stress hormone. When our cortisol stress hormone is up, that actually kind of breaks down muscle, and it also forces us to kind of hold on to fat. If we have poor sleep, then that actually drives up our cortisol. So a lot of it actually comes back to what sort of lifestyle changes can we make to reduce or optimize the hormones that will impact, our weight or our hunger. So reducing cortisol, stress management, let's say it's meditation, exercise, good quality of sleep, that will reduce cortisol and actually reduce our appetite. And then other things, obviously, like estrogen and progesterone in women, testosterone both in women and men, those can definitely affect appetite. And particularly for women, when they go through menopause, a lot of their cravings will tend to change during that time because estrogen plays a key role in glucose metabolism and really all aspects of our health.
Next question here. What tests can be run to look for an underlying cause of not losing weight, assuming nutrition and exercise appear correct?
Yeah, so I always start with some basic labs because obviously I don't want to miss other conditions which could be contributing. So that would include just a complete blood count, a comprehensive metabolic panel that looks at a lot of electrolytes, the kidney function, and the liver enzymes. I will often check a fasting insulin level, and that will tell me, even in the setting of a normal hemoglobin A1C, which looks at our 3-month blood sugar control, if I see someone's fasting insulin level continue to increase, even in the setting of a normal A1C, I know that they're actually maybe developing insulin resistance that we need to kind of tackle. Other labs would be an advanced lipid panel, so far beyond just the basic lipid panel that shows us triglycerides, LDL, HDL. I want to look at actually lipoprotein little a, which is a genetic predisposition, high levels for cardiovascular disease, and lipoprotein B, which is also another risk factor. Additional labs would be thyroid, like the TSH, and then really a full thyroid panel. HSCRP, which is an inflammatory marker and shows us kind of total body inflammation. The hemoglobin A1C, like I mentioned. For my male patients, I always check a total testosterone to start with. Typically, I don't check hormones in women because they're constantly fluctuating and they're really hard to interpret. So those are pretty, basic labs that I start with. Obviously, depending on the person, there may be other things that I check, but those are some pretty basic ones that all patients should have.
So next question here, how does a ketogenic diet affect gut health? I think we touched on that briefly, but we had that.
Yeah, so ketogenic diets are very high in fat. Again, any diet will work at least in the short term. So if you have to restrict your diet so much where you're only having high fat foods, you end up actually oftentimes eating less calories. Fat also stays in your stomach the longest when you compare it to all the other macronutrients like protein and carbs. So it's very filling for people. The problem is on a ketogenic diet is you're basically taking out a lot of your fiber sources. And really for optimal gut health and protecting our immune system and good bowel health, we need about 25 to 35 grams of fiber per day. That would be nearly impossible to do on a ketogenic diet. So it all comes down to protecting your gut microbiome, protecting our immune system, having good bowel movements, and that's really hard to do on a ketogenic diet long term.
Next question here. Do you recommend probiotics and digestive enzymes?
Yeah, so the supplement industry is massive. The problem is that it's unregulated. So a lot of the probiotics out there are made in, manufacturing factories that are not regulated, and they actually don't even have viable organisms. And we don't have enough data to say okay, I have bloating, I need X amount of colony forming units of lactobacillus versus bifidobacteria. So everyone has different conditions and we don't quite know which bacteria someone needs, how much they need, and whether or not the product actually has a viable probiotic in it. So I actually keep it pretty simple. Probiotics are important, but I try to get my patients to eat them in food, whether it's kimchi or sauerkraut. The Greek yogurt is great. It has like six different strains of probiotics. So that's really where I recommend for patients is trying to get it through food. And that's really beneficial bacteria for our health. And then the other question was, what was the other component? Oh, digestive enzymes. So, unfortunately, a lot of the stuff in our food and ultra processed food has a lot of ingredients our body doesn't recognize. I mentioned earlier the natural flavors has 100 different chemical compounds, including emulsifiers and other things. So a lot of times, when people have digestive issues, it has to do with one of, 50 ingredients that are in the food. So we want to actually go back to the ingredients list and try to minimize some of those foods. And then oftentimes people are going to feel better. So unless someone has like a digestive issue, whether they've had, let's say, a gastric bypass where they need some enzymes, or they have, pancreatic insufficiency, most people, as long as we're paying attention to our diet, we're chewing our food, which allows for proper digestion, most people will not need an added digestive enzyme.
Next question here. This person says they have a gluten intolerance and they're wondering if the weight loss meds that we covered tonight happen to be gluten-free.
So I'd actually have to check the label. I know for, most pills, they're going to tell you that they're gluten-free. A lot of supplements, you also need to check that. As far as these medications, it doesn't say on the label that it's certified gluten-free, but I'll actually have to check that. But that's a great question. Now, with, if you have celiac disease, it would be paramount that you are gluten-free. In people who, let's say, have an intolerance or a sensitivity, it's not necessarily as important unless you have significant side effects related to it.
And the next question here, this person is asking if there are any good cookbooks that you may recommend for someone who is living alone on the weight loss.
Okay, perfect. So the nice thing is with the internet, there's a million things that you can find on the internet or social media. The problem is some of it, they kind of claim to be healthy and it's not so healthy. I really like Mary Claire Haber's book, The Galveston Diet. It is an anti-inflammatory diet. It's really geared towards menopausal women, but I think it also applies to really any gender. And there's a lot of great recipes in here that are really focused on whole food, plant-based. Right now I'm looking at a chocolate peanut butter yogurt that has Greek yogurt, peanut butter, cocoa powder, and chia seeds. That sounds delicious. So this is one that I recommend. A lot of really good recipe options in here. And then I think another person actually mentioned one of the questions as well. They asked me if I had read this book. It's Eat to Beat Disease. So it talks about the impact of food on our health, things that we can do to really boost our immunity. And it actually contains a bunch of recipes in here as well. So I would recommend these two books to start with. Again, a lot of stuff on social media. The problem is on social media, I've noticed with a lot of these influencers, is they're promoting a lot of supplements, and a lot of these supplements and protein shakes are ultra processed. Okay, so we actually have an educational site, so you can scan the QR code on the left here. That's our Pearlman MD site that has a lot of nutrition and GI related and gut health blogs and articles on there for you to check out. Our practice site, which is Prime Institute, we have our social media handles here. Our website really just goes over our practice information. We have a ton of videos on nutrition and how to get rid of sugar cravings and reduce added salt, how these medications work, how to minimize side effects. You can check us out on our Prime Institute YouTube page. And then I post a lot on my Michelle Pearlman MD Instagram page. I actually post a lot of my own recipes that I use and a lot of tips and tricks that I tell my patients. So tons of information on all of our sites here and on social media. We love to engage with the community. Our goal is truly to educate and empower you to make better choices, and it all starts today. So I want you to all ask yourself, how are you going to start off tomorrow morning the best way possible? And it may be that you go for a walk, and maybe you order that weighted vest on Amazon, or you cut out the sugar in your coffee, but it's just taking that next right step. And then BiteMD, so I'm also CEO and co-founder of this nutrition platform. So you can check it out at BiteMD, BYTEMD.app, or scan this QR code. We have actually a lot of educational content on this site as well that goes over more GI related conditions, whether it's small bowel overgrowth, hiatal hernias, heartburn, or bloating, and how to really optimize your nutrition to influence those side effects. And then if you subscribe to our newsletter, we'll update you on our launch. We're actually building out a whole nutrition mobile application where you're going to be able to scan a picture of your meal. We identify all the ingredients. You're able to track a GI symptom like heartburn, nausea, bloating, or diarrhea, and then using machine learning and AI, it will actually help identify what that ingredient may be that caused your trigger. So stay tuned for that, but definitely subscribe to BiteMD. You'll get our newsletters, check out our content, and look out for our launch.
If you'd like to learn more about weight loss and weight management, you can visit the MenMD page to view instructional videos, guides, expert articles, and more. These will be found on the Resource Center. If you still have any questions following tonight's event and we did not get to your question, you can call MenMD at 857-233-5837 or log into the MenMD portal to schedule an appointment with a MenMD personal health assistant.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.